রাতের অন্ধকারের পর পৃথিবীর দিগন্ত জুড়ে দেখা যায় সূর্য। সূর্য তার নির্ভরযোগ্যতার সোনালী আভা ছড়িয়ে উপহার দেয় একটি নতুন সকাল। সৃষ্টিলগ্ন থেকে পৃথিবীর সকল প্রাণের বেঁচে থাকা ও বেড়ে ওঠার জন্য অপরিসীম শক্তির যোগান দিয়ে আসছে সূর্য। সূর্যের মতোই নির্ভরতার প্রতীক হিসেবে বিশ্বজুড়ে মানুষের কাছে উচ্চ গুণমান সম্পন্ন ওষুধ পৌঁছে দিতে ও ইতিবাচক প্রভাব স্থাপনের লক্ষ্যে ১৯৮৩ সালে যাত্রা শুরু করে সান ফার্মা। খুব দ্রুত এই দীর্ঘ পথ পাড়ি দিয়ে সান ফার্মা আজ বিশ্বের অন্যতম বিশেষায়িত জেনেরিক ফার্মাসিউটিক্যাল কোম্পানি, যার ৬টি মহাদেশে ৪০টিরও বেশি উৎপাদন কেন্দ্র রয়েছে। আজ বিশ্বব্যাপী ১০০টিরও বেশি দেশে ২০০০-এরও অধিক ওষুধ উৎপাদন ও বিপণন করে সান ফার্মা। গবেষণা এবং উদ্ভাবনী প্রচেষ্টায় সান ফার্মার জন্মলগ্ন থেকেই প্রাধান্য দেওয়া হয়েছে সমাজের সর্বস্তরের মানুষের সুস্বাস্থ্য, যা প্রতিটি জীবনকে করে তোলে আরও সুন্দর। উদ্ভাবনী উৎকর্ষতা রয়েছে সান ফার্মার অন্তঃকরণে। প্রায় ২০০০ জন গবেষকের মেধা এবং নিরলস পরিশ্রম আমাদের তৈরি করতে সাহায্য করেছে অনেক অসীম কার্যকরী ওষুধ, যা নানাবিধ রোগের যেমন মাথা ব্যথা থেকে জটিল ক্যান্সারের চিকিৎসায় অপরিসীম সফলতা প্রদান করেছে। ওষুধের গুণগত মান বজায় রাখতে আপোষহীন সান ফার্মা। তাই নির্ভরযোগ্যতা, মান, উদ্ভাবন, আস্থা এবং ধারাবাহিকতা, সান ফার্মার এই সকল মূল্যবোধের ওপর ভিত্তি করে বিশ্বব্যাপী সান ফার্মার স্বাস্থ্যসেবা উদ্যোগের অংশ হিসেবে ২০০৪ সালে গড়ে উঠেছে সান ফার্মা বাংলাদেশ। বিশেষায়িত বিভাগসমূহ যেমন উৎপাদন, বিপণন, বিক্রয়, সরবরাহ, মানব সম্পদ, গুণাগুণ নিয়ন্ত্রণ সহ বিভিন্ন বিভাগে আজ ৬৫০ জনেরও বেশি সুদক্ষ, অভিজ্ঞ ও নিবেদিত কর্মী সুনিপুণভাবে নিরলস কাজ করে যাচ্ছে বাংলাদেশের মানুষের সুস্বাস্থ্যের জন্য, তাদের জীবনের জন্য। এই মুহূর্তে বাংলাদেশে সান ফার্মার ৫০টিরও বেশি ওষুধ রয়েছে। সাইকিয়াট্রি, নিউরোলজি, কার্ডিওলজি, গ্যাস্ট্রোএন্টেরোলজি, ডায়াবেটোলজি, অর্থোপেডিক্স সহ বিভিন্ন সেগমেন্টে আমাদের ওষুধসমূহ চিকিৎসক, অন্যান্য স্বাস্থ্যকর্মী এবং রোগীদের নিকট সুপরিচিত। গুণগত মানের দিক থেকে সান ফার্মা বাংলাদেশের সব ওষুধই সম্পূর্ণ আন্তর্জাতিক মানের। সান ফার্মার আন্তর্জাতিক গবেষণা কেন্দ্র থেকে টেকনোলজি ট্রান্সফারের মাধ্যমে বিভিন্ন জটিল প্রযুক্তির বিশ্বমানের ওষুধ উৎপাদন করে থাকে সান ফার্মা বাংলাদেশ। আর এই ওষুধ উৎপাদনের প্রতিটি ধাপে আমরা সর্বোন্নত প্রযুক্তি ও অত্যাধুনিক যন্ত্রপাতির মাধ্যমে এর গুণগত মান নিশ্চিত করি সর্বদাই। আমাদের রয়েছে সম্পূর্ণ হাতের স্পর্শ ছাড়া বিভিন্ন অত্যাধুনিক যন্ত্রপাতি, যা উৎপাদনের প্রতিটি ধাপে আমাদের ওষুধের সর্বোচ্চ গুণমান বজায় রাখতে সাহায্য করে। গাজীপুরের আমাদের নিজস্ব উৎপাদন কেন্দ্রে আমরা প্রতি বছর ২২ কোটিরও বেশি বিশ্বমানের ট্যাবলেট, ক্যাপসুল উৎপাদন করি এবং দেশের বিভিন্ন প্রান্তে বিস্তৃত নেটওয়ার্কের মাধ্যমে হাসপাতাল ও ফার্মেসিতে আমাদের ওষুধ সরবরাহ করি। সূর্য যেভাবে প্রাণের বিস্তৃতি ঘটায়, ঠিক সেভাবে বাংলাদেশের মানুষের দেহ ও মনের সুস্বাস্থ্যের জন্য সান ফার্মার এই নিরলস পরিশ্রম আস্থা কুড়িয়েছে সকলের। এভাবেই সবার ভালোবাসা আর নির্ভরতার প্রতীক হিসেবে এগিয়ে চলুক সান ফার্মা, আর সর্বদা হাসি মুখে থাকুক বাংলাদেশের মানুষ। সান ফার্মা বাংলাদেশ, মানুষের পাশে, জীবনের পরশে।
A very good evening, respected doctors, and warm welcome to Clinical Excellence Program for Diabetes Practitioner in Bangladesh. Dear doctor, this is a unique initiative for Sun Pharma which aims to enhance your clinical knowledge in the field of diabetology. This scientific program is arranged under the banner of Diabetic Association of Bangladesh, BADAS, and in the collaboration with International Federation of Diabetes and Cardiometabolic Disorders, IFDCD. We are grateful to respected Professor Ajaz sir for being guide in the advisor in preparing the curriculum in the program. IFDCD is an international organization based in Amsterdam, Netherlands, and that focus on updating clinical knowledge and skill of physician, diabetes, and cardiology cardiac care professional in the field of diabetes and cardiometabolism disorder. Sun Pharma Bangladesh is proud to be knowledge partner in the enhancing the clinical knowledge and practice in the field of diabetology. Keeping in line with the same, we have formulated this program, which comprise with the two enhancing online webinar from faculties of IFDCD and India on the management of type 2 diabetes. Today, we will have the first webinar from international faculty on approach to identifying and diagnosing complication in T2DDM, with the most learning point illustrated from the point of view of day-to-day practice. I am sure that the program will meet your rich academic expectation, that your practitioner in this event will be fruitful. Now, let me have this to introduce to the program advisor, Professor Azad Khan. Professor Azad Sir, National Professor of Bangladesh, 2021, Regional Chair, IDF Southeast Asia, President Diabetic Association of Bangladesh, and more than 250 journal published. Let me also introduce you to the moderator of the today program from the medical team, Dr. Jayanto Dev. Dr. Jayanto Dev, Manager, Medical Affairs of Sun Pharma in Mumbai. Now I invite Dr. Jayanto Dev to introduce the eminent speaker and of the panel of experts of today's session. Thank you.
Thank you, Mr. Shamol, for the kind introduction of Professor Azad Khan and myself. I'd like to take the pleasure of introducing our international speaker for today's program, Professor David Strain, and he's basically currently from the clinical senior lecturer and honorary consultant from the University of Exeter Medical School, Institute of Biomedical Clinical Sciences. His main research focus is the health of older adults with diabetes, ensuring the right patient gets the right treatment. This includes research across spectrum of mechanistic studies in biologically young to pragmatic trials in the frail elderly population. He also runs a community diabetic service for the older adults, works in an patient stroke consultants, and he's a doyen in the Department of Diabetes and Vascular Research, Royal Devon and Exeter Hospital, Barrett Road. Along with our eminent speaker, Professor Strain, we also have 3 eminent panelists. And I have the pleasure of introducing Professor Farooq Pathan from Bangladesh, Dhaka. He's the director of Burdem Academy since 2021, and is the chief palm of Bangladesh Endocrine Society, former president of AACC Bangladesh chapter in 28, SAFES, that is South Asian Federation of Endocrine Societies, between 2015 to 17, and Bangladesh Endocrine Society from 17 to 21. He again has more than 100 publications in national and international journals. Our second panel expert is again Dr. Faria Afsana, who is an associate professor and unit head from the Department of Endocrinology, Burdem, Dhaka. He's vice president and at BES, president-elect at SAFES this year, and he has around 78 publications in national and international journals. Also, we have with us Dr. Abdul Samad. He's the Chief Executive Officer of NHN since May 2008. As our final panelist, he's a member of ADA, AAC, and ESD, and he's participated in various national and international conferences in diabetology. I would like to welcome all of you for taking out your time, and we'll take forward into the program from Professor Strain.
Thank you so much. Now I'm just going to share my screen and make sure that you can see this okay, he says. Bum, bum. I'm hoping you can all see the screen okay. I'm looking at Professor Khan just to see if to make sure that that is the case. Perfect. So thank you. It is such a privilege to be with you, to be giving this talk. And over the next 40 minutes or so, I'm going to be talking about an approach to identifying and diagnosing the complications of diabetes. And this is going to take a far broader conversation than just measuring the HbA1c, measuring the glucose, and seeing what to do thereafter. Because actually, diabetes is a far more complex disease than just that. So I'm going to start as usual with my conflicts of interest. I am receiving an honorarium to give this talk today. However, I have prepared all of the slides my own. They're all my own material, many of them my own studies, and therefore there's been no outside interference or involvement in creating this slide deck or with anything I'm going to be saying. I also start every presentation I do with this slide. This is my disclaimer. These are the words of Abraham Lincoln, who very famously said, "Never allow scientists to partake in government. If you give them a new piece of information, a scientist will change their mind." Now, I use this for many reasons, but predominantly because actually in early diabetes, both in the diagnosis, the management, and the interaction with the comorbidities, there is a massively rapid evolving information set talking about how best to manage this. And therefore, what I'm saying today may not still be the case tomorrow. It may not be the case in 12 months' time. But this is the best of the information that we have at this moment in time. So I was asked to talk about the diagnostic criteria for diabetes and the metabolic syndrome and how this all fits together. And I can actually do that very, very simply. These are the numbers. These are the numbers that we need to be looking at on a regular basis. We look at the HbA1c, we look at the fasting plasma glucose, or we look at the oral glucose tolerance test. And in order to make the diagnosis of diabetes, you need symptoms plus any one of these. If they're asymptomatic, you need 2 of these tests in order to find out what the right strategy for treating our patients is. And these numbers are really, really simple. The fasting plasma glucose, the HbA1c, if it's less than 5.7%, that's normal. If it's 5.7 to 6.4%, they're in a pre-diabetes range. And if it's greater than 6.5%, then they have diabetes. That's very, very important to be aware of the fact that that is based on a normal hemoglobin without any blood loss and without any other hematological diseases. So our patients with thalassemia, patients who may have other diseases that are causing hemolysis, patients who might have increased blood turnover, their A1Cs will be artificially changed. Remember, your HbA1c is an average of the exposure to your glucose to the average of the life expectancy of the red cell. Providing that red cell is lasting for 3 months, this is a valid measure. If the red cells have a protracted duration, so for example, the very elderly patients whose red cell life is much longer, or patients who've got diseases like thalassemia or sickle cell, or patients who are losing blood through GI disturbance or infectious diseases, then an A1C will not be valid. And for those individuals, we have to look at an alternative route of making the diagnosis. The next thing that we may look at are the fasting plasma glucose. Now, fasting plasma glucose gives you the snapshot of the glucose at that one particular time. And if it's less than 100, you are fine. If it's 100 to 125, you're in the pre-diabetes range, and greater than 126, you are regarded as having diabetes. The problem with fasting plasma glucose is there are other things that can influence it. remarkably stressful events, right down to what you actually ate, when you finished eating, and what your night's sleep was like in order to determine it. So although for years the fasting plasma glucose was accepted as a standard, there is a greater push recently to switch, if you can't do an A1C, to do the oral glucose tolerance test. That is, you give them 75 grams of sugar, and then you find out what happens to their blood sugar afterwards. And if your blood sugar rises at 2 hours to less than 140, you don't have diabetes. 140 to 199, you're in the pre-diabetic range, and 200 or above, you have diabetes. Now, you'll notice that these numbers appear somewhat rounded. These numbers appear rather arbitrary. And the reason for this is very simple. They are. Diabetes is a continuum. Diabetes is not necessarily an absolute cutoff. The majority of people living with diabetes have been in a pre-diabetic state for 6 or 7 years before their first glucose is arrived. The reason that those particular numbers have been chosen is, well, that was based on historic figures that said this is where the risk of diabetic retinopathy suddenly starts to shoot up. And if your diabetic retinopathy shoots up, then there is chances are that other diseases will also be shooting up at a similar time. And that's the sole reason about why we have these percentages cut-offs. And this concept of diabetes and glucose and the management of diabetes and glucose is by no means new. It was recognized 3,500 years or so ago. Actually, one of the first people who recognized this was the physician Hesi-Ra, an ancient Egyptian physician of around 1552 BC, 1552 BC, who described this condition that was affecting the affluent. It was affecting people of greater girth, he described it. Basically, the people that we would today recognize as having insulin resistance. The central adiposity, the visceral adiposity that we know is associated with insulin resistance. And it's associated with frequent urination. And he treated this with an extract of the French lilac. French lilac, otherwise known as goat's rue, or today, we would call that metformin. And actually, the management of type 2 diabetes from the outset has been recognized to be metformin, not since 1958 when the drug was first developed, but for 3,500 years since Hesi-Ra was first using this as a treatment for his patients living with this disease. Now, there has then been a significant evolution of the management of diabetes over the last 15 to 20 years. If you go back to 2007, we managed diabetes on a three-pronged approach, because actually the understanding of diabetes was that you weren't making enough insulin. The insulin you were making was being inhibited, it was impaired action, and that you had a dysregulation of your glucose metabolism. You had an increase in the glucose absorption. And therefore, our management of diabetes was based around those three key goals. We had the alpha glucosidase inhibitors that we were able to reduce the glucose uptake. Impaired insulin action, the insulin resistance was tackled with thiazolidinediones and metformin. For beta cell dysfunction, we would stimulate the beta cells with sulfonylureas or the glinides, repaglinide or nataglinide. However, this all changed dramatically when Ralph DeFronzo in 2009 published that glycemic control was not the root problem in diabetes. Actually, glycemic control is no more than a symptom of diabetes. It was a significant shift in the way we started to think about diabetes. And Ralph DeFronzo presented the Banting lecture at the EASD and then went on to write this landmark paper that said hyperglycemia is a symptom of a disease. The disease itself is characterized by reduced alpha cell production of glucagon, reduced beta cell production of insulin, of incretin deficits, the changes in the GLP-1, the GIP, of changes in our relationship with food, this neurotransmitter that a patient living with diabetes actually doesn't feel full in the same way as somebody without diabetes. They are therefore hungry much, much sooner and would like to eat their next meal. They have a change in the relationship between glucose and fat metabolism, such you see an accelerated lipolysis, but this will be very low density or LDL fat that's released. And as a result, this has a far more atherogenic effect. Our muscles are not able to utilize the glucose properly. The effect of this is people living with diabetes have a reduction in their efficiency of about 20%. That's why for exactly the same effort, for exactly the same muscle mass, a patient living with diabetes will experience a generalized weaker response. The livers change their interaction, that they will increase glucose production even at a time that they've just eaten a high carbohydrate meal, therefore further fueling the central adiposity. And once we've got used to that, once this glucose is elevated, the kidneys stop excreting it. They start upregulating the SGLT1 and 2 pathways that cause an increased glucose retention. So even when there is hyperglycemia, the body doesn't deal with it in the usual way. Now, this sat in the right place until about 3 years ago. And 3 years ago, we added in that there is a change to the microbiome. There is a change to the way that the gut is associated with glucose. There was some really elegant work done originally with rats that demonstrated if you change the microbiome, those bacteria living in our gut, you can actually change the glycemic dysregulation. It was also highlighted that the entire inflammatory pathway was modulated in people with diabetes, even in the setting of normal glucose. So glucose management itself was not on its own right able to fix people. We also saw that there was a change in the gastric absorption of glucose, that it would be reduced in the stomach in people living with diabetes. That meant it was more likely to get to the lower bowel, where it would have a different impact on the incretin system. And similarly, it would cause some of this microbiome dysregulation. Now, the microbiome dysregulation and the reduced amylin that leads to increased glucose absorption in itself are very closely interplay. And there's still an uncertainty today as to which comes first. Is it you change your glucose absorption, which then changes your microbiome? Or does your microbiome change, which causes differences in your amylin secretion and therefore your glucose uptake? Whichever of those it is, the net result is the hyperglycemia that we see. However, with all of this, you can see that hyperglycemia is nothing more than a barometer. Hyperglycemia is very often not the underlying disease. It's like taking a temperature of a patient who's got pneumonia. Fixing that temperature, giving them the cold baths or the paracetamol is not going to take away the pneumonia. Measuring the glucose is an indicator of inflammatory dysregulation in neurotransmitter dysfunction and insulin resistance, but fixing the glucose doesn't take away those particular elements. Now, things were then latterly made further complex by the identification that diabetes itself is not a single disease. Although we recognize diabetes as hyperglycemia, then actually it's a whole load of different characteristics. There is a classic insulin-resistant diabetes, which does account for a large number of people living with diabetes. We then see severe insulin deficiency diabetes. Now, this, even in the setting of type 2, is just down to pancreatic failure. And we know, particularly with sarcopenia, with frailty, with our very elderly population, their pancreas can fail in exactly the same way as every other organ can fail. And these look, to all intents and purposes, like a person living with type 1 diabetes. They'll present with diabetic ketoacidosis, they'll present with catabolism, weight loss, and all of those things that go with that. And they usually require early insulinization. At the other end of the spectrum, we've got this mild age-related diabetes. This is something we see in older adults in their 8th or 9th decade. And what we see here is just the red cell duration lasts a bit longer. You get reduced erythropoietin and then a reduced red cell turnover. So your same glucose has a greater chance of bumping into the hemoglobin, and you see this artificial elevation of your HbA1c. There is a question at the moment as to whether these people need treatment at all. And these do have quite a significant implication when it comes to managing patients living with diabetes. Now, for the rest of this talk, I'm going to be focusing mostly on the insulin resistance phenotype. And the reason for that is twofold. The first is this is the one that we know most about. This is the one that we've got lots of therapies for. And the second, by far and away, this is the most common form of diabetes that you will see in Bangladesh. In Bangladesh, this accounts for about 90 to 92% of the type 2 diabetes that you'll see. And that component fits as a core element of this whole cardiorenal metabolic system. And again, this is another development of the management of diabetes. The cardiorenal metabolic system is being more and more identified as a single entity. The heart is by far and away the most metabolically demanding organ in the body. It is incredibly susceptible to changes in volume, change in metabolism, changing in workload. And it can only do this providing it is mirrored with the right amount of support from the energy and also the right amount of support when it comes to waste products elimination. Energy is maintained by the liver and the pancreas, whereas the kidneys are involved in the homeostasis of the glucose and the volume, and also the regulation of the perfusion that it manages to achieve. And all of these systems are significantly interrelated. If one goes wrong, you can expect the other two to start failing. When we start to see failure in metabolic regulation with the liver and the pancreas, with insulin resistance and diabetes, the heart cannot function normally. The kidneys cannot excrete properly. So you will see decline in both of them. If you start to get heart failure, you get lack of perfusion, which means the tissues stop to experience the nutrients and the insulin that they require. Therefore, they send the catabolic messages back to the body, which in turn triggers the renal impairment. If you get renal impairment, then what you see is a volume expansion. You see the pollutants hanging around in the body much longer. Therefore, neither the heart nor the metabolic pathways are able to work appropriately. The net effect of any of these three is it will trigger problems in the other two. And therefore, when we're considering our patients with diabetes, we have to consider where do they fit on this entire continuum? Where do they fit on the endothelial dysfunction, the atherosclerotic, the cardiac disease, the renal impairment, the heart failure, and what is the glycemic actually representative of? Now, I've spoken about these three interplaying. There is a fourth condition that is rapidly being recognized as having a significant component of this. And this is really only in the last 2 to 3 years that we're starting to appreciate that when you get the metabolic problems coming from the pancreas and the cardiac dysfunction and the renal dysfunction, the liver also starts to suffer. And we are seeing a dramatic increase in patients living with type 2 diabetes, with obesity, with the non-alcoholic fatty liver disease, or the subsequent iterations of that with NASH, and living with CVD. And all of these diseases are interplay. So therefore, if you are working with any one of these diseases, you are automatically working with all four. And then the knock-on effect is absolutely huge. Any patient living with adiposity, living with obesity, is going to be associated with a considerable other condition. So if, for example, you're seeing somebody in an asthma clinic or an infertility clinic, they are far more likely to be living with obesity. And if they are living with obesity, they will then have many of these knock-on consequences, and fixing them might improve the underlying condition that you started seeing people for. They also get mechanical problems. So we see difficulties with physical functioning. Low back pain occurs in about 80% of patients. And actually, a very common presenting feature for any of these diseases would be presenting through their primary care practitioner as a simple, I am struggling to do my work because of the back pain that I'm getting. All of these will have a knock-on impact on the mental health of our individuals. And a patient living with obesity and chronic comorbidities will have an incredible level of depression, anxiety. Their ability to be productive will have a dramatic impact on their feelings of self-worth. Very often, this can cause family problems. This can cause issues where they are not able to contribute to the family structure in a way that they ordinarily would do. And now, going back through each of these in turn, I'm just going to take a moment to talking about how we can hopefully tackle this coming through. And the first thing I will look at is obesity. Now, obesity is a complex multifactorial disease. We always used to be told that it's just a balance between too much in, not enough out. Then people started recognizing that there are neurological reasons associated with it that come in from the environment. Once upon a time, that it was prolonged periods of fasting was normal. These days, with the fast food and the environment and the socioeconomic pressures, it is almost impossible to get to a phase where we are not being tempted by foods that otherwise we may not have eaten. And the food companies are very much invested in making these more pleasurable. And in doing so, you're far more likely to engage. Now, the knock-on effects of all this affects our adipose tissues, the pancreas, the guts, the genetics, and the medications all lead into this. But actually, if we take the first of this, the adipose tissue, the pancreas, and the gut, that then becomes a positive feedback loop. That having problems with the food regulation actually triggers a positive feedback loop, such that if you eat more, your body enjoys eating more, and therefore you are convinced to eat more. Now, it's not quite as simple as just food on a plate, therefore you eat more food, because many of the hormones produced by the adipose tissue, the pancreas, and the gut are directly affecting the prefrontal cortex, the bit of our brain that determines when we're going to eat. They are then potentiated by the hedonistic inputs, right? The fact that you get pleasure out of eating certain foods. Now, there are different regulators of that, by the availability, the social cue, the food thing. But whatever those cues, they are all feeding in to the way that our hypothalamus responds. Now, the hypothalamus responds differently to food dependent on what stage of the disease process you're in. It produces a whole host of different chemicals to upregulate or downregulate satiety and hunger. So we'll see things like arginine-related peptide that will actually inhibit satiety. It will tell you that you are not full. I don't care how much you've eaten, you need to eat more. And many of the chemicals that are produced that in order to try and prevent that, we start to lose in the management of diabetes. So leptin and insulin, for example, should trigger satiety. They should suppress hunger. But the reality is, if you start to lose sensitivity to these components, you eat a meal, you produce insulin, but your body doesn't know it's full. And therefore, an hour later, you become hungry again. The satiety peptides similarly will give you an altered response. We see in people living with diabetes that they have reduced levels of GLP-1, glucagon-like peptide 1, which is a really potent appetite suppressant. But the levels start to fall and the sensitivity starts to fall. We see polypeptide PYY, also start to have its effect within the satiety centers. Ghrelin ceases to be produced, and all of this interacts with the hindbrain. And what we see is a change in the way our patients living with diabetes or obesity interact with food. Now, these primary neurons start to impact on the way that the body interprets its food cues. And as a result, we see patients self-perpetuating this obesity that has the longer term consequences. And so what we end up in a position is that we need to start tackling this at root cause. The days of managing obesity by saying, eat less, do more, have gone. We need to start tackling each of these consequences individually, and the sooner and better, because unless we do, we end up with the pathology digging in. We end up with hypertrophied adipocytes that become less effective at producing their satiety hormones. We see endothelial dysfunction, which leads to cardiovascular disease, and we see increased fatty liver, which changes your fat metabolism, and in doing so also causes more atherosclerosis. We see changes in the activity of the pancreas and the muscles. The net effect of all of this is obesity does not just cause the waist circumference to expand. It causes a substantial change in the way that that our entire body is able of functioning. And the sooner we treat that, the better. Waiting till patients need interventions with injectable therapy or even surgery actually is a much more difficult challenge to gain benefit. If you can get to someone with a healthy BMI of about 18.5 in a Bangladeshi population and stop them rising, it is far more effective at preventing each of those complications. But the more weight you lose, the greater the benefit. And earlier interventions with drugs that promote the weight loss, such as metformin, such as the DPP-4 inhibitors that produce a more regulated interaction with food, will have a much greater impact when started earlier in the disease process. And the sooner we start it, the sooner the benefit. Because once it's entrenched, then we see this three-way dysfunction. The cardiac dysfunction in itself leads to hepatic dysfunction, and hepatic and pancreatic metabolic dysfunction leads to renal dysfunction. And each of these elements have the interplay such that the majority of the patients that we see will have problems in one or other of the domains if any one goes wrong. I just want to take a quick moment to go through some of the diagnostic criteria. And for many of you, this will be second hat, but I just want to take a moment to talk about how we are doing some of the other diagnostics. So, for example, glomerular filtration rate is actually something that's relatively new since I started as a doctor. When I was a trainee, we just measured creatinine, and creatinine was all we needed to look at. We've now moved to almost universally measuring the glomerular filtration rate. And the EGFR, estimated glomerular filtration rate, is a composite of two particular variables. How much every single glomerulus will filter and how many glomeruli you've got left. And we calculate this using equations based on the renal function, the creatinine, the body weight, the gender, and the other components. But the problem is, as your kidneys start to fail, as you start to lose glomeruli, the remaining glomerular heads have to start working harder. We know people living with diabetes actually have a dramatic reduction in the number of glomeruli. But each individual glomerulus then has to work much, much harder in order to try and compensate. As they start to work harder, that's the point that the basement membranes start to fail. And as they're working harder, they are then more likely to fail. So there becomes a catastrophic decline in the number of glomeruli. But by the time the decline starts, then it's actually too late to manage the underlying disease. And because of that, when we're looking at the diabetic kidney, we've moved away from just monitoring eGFR and are focusing far more about albuminuria and microalbuminuria. See, the reason is, as your glomerular pressure increases, as your filtration rate shoots up, before your eGFR starts to fail, the first thing that happens is these glomeruli become leaky. As a result, what we then start to see is leakiness that measures as changes within the microalbuminuria. Here's just an example, and I want to stress this is just an example that I've drawn out. It's not taken from any real patient, but this is a typical sort of course that would happen to the eGFR in a person living with diabetes. That the eGFR in the first stages would rise. That's because of the diuretic effect of the glucose, tied in with the fact that as glomerular heads start to fail, the upregulation of the remaining glomerular head actually overcompensate. And therefore, your kidneys have lost a dramatic amount of their activity before we start to detect the fact that the kidneys have gone wrong. But as I said, the albumin excretion rates starts to go up as soon as the glomerular heads start to decline. So if you monitor the urinary albumin excretion rate, you start to pick up the disease much, much earlier. So the standard that we are looking at now for monitoring our patients living with diabetes is not waiting for the creatinine to start fail, waiting for the eGFR to fall before we intervene. The standard now is looking early on. Try and identify problems before they arise and prevent them getting worse. Now, when it comes to looking at the failure, eGFR is very tightly associated with mortality, both cardiovascular mortality and all-cause mortality. I'm going to skip over this slide very quickly because the next one actually gives us the more important information. What you've got here is a complex 3D graph, but what you've got on the left-hand side are people with normal, with microalbuminuria, and with macroalbuminuria. On the right-hand side, you've got people with normal eGFR, with a marginally elevated eGFR, reduced eGFR rather, and then with renal impairment. And you can see that the association between the kidney disease and the mortality is far more dependent on the micro and macroalbuminuria. Indeed, the cardiovascular death is higher in someone with microalbuminuria and a normal eGFR than it is in someone with a reduced eGFR and no microalbuminuria. Therefore, when it comes to monitoring our patients, microalbuminuria is the first indicator that you have a potential pathology. And the pathology is very rarely renal failure. Very few people with renal disease actually die of renal disease. They die of the cardiovascular events that it causes. This is the graph that is looked at very, very frequently. What we see that if you are age 60 without diabetes, you've got a normal life expectancy. Whatever that may be for your geographic region and for the other demographics, it's normal. Just adding diabetes on top of any other diagnosis will knock 6 years off your life. With CKD, that knocks 9 years off your life. It's only another 2 years if you've had a heart attack or a stroke. And we tend to think of heart attack and stroke as being the major life-limiting event, when actually the diabetes plus the CKD have knocked off about 85% of your life years that the heart attack and stroke ultimately goes for. And that brings us on to the different diagnoses that we start looking at when we talk about the cardiovascular disease, because we tend to talk about cardiovascular disease as made up of the three big pillars. Cardiovascular death, rather obvious to diagnose, the patient is dead of a cardiovascular cause. And actually for these patients, we can do absolutely nothing. They're dead. However, what we are far more interested in is those early signs. those with myocardial infarction, that we want to try and reduce the risk of this happening. Because the myocardial event, although a discrete event, will leave longer term consequences. It can leave valve dysfunction, it can leave atrial and ventricular dysrhythmias that can have a dramatic impact on quality and quantity of life. We're increasingly recognize that a myocardial infarction causes a central nervous destabilization. And this is one of the reasons that we believe an MI leads to subsequent diabetes. But of course, there's the overall medical costs, there's a loss of productivity and the caregiver costs. So these are all essential components we have to have conversation with our patients when we're talking about going forward. We then have strokes. Strokes have a massive debilitating cause. It's the second leading cause of death globally, and it's one of the biggest cause of reductions in the quality of life of any of our patients. Now, there are many factors that can have an impact on this. There's many factors that are within our control. There's many of them that are without our control. But we have to look at what we can do in order to try and minimize the risk. And when we're managing our patients with diabetes, we manage the entire cardiometabolic consequences. Now, from that, I just want to touch briefly on heart failure, because we speak about the 3 pillars of cardiovascular outcomes being cardiovascular death, myocardial infarction, and stroke. But heart failure is a very important but under-recognized complication of the disease. It's very often the first presenting feature of cardiovascular disease in a patient living with diabetes. There have been several studies that have identified it in people without a proven MI. In my own MD work, I was looking at the impacts of cardiometabolic disease in different ethnic groups. And one of the key things that we identified is that actually heart failure is a far more common than we ever gave credit for. About 68% of our population will have some degree of LV dysfunction within 5 years of the diagnosis of the disease. About 28% of patients with type 2 diabetes will have some degree of heart failure once they've reached the age of 60. And one of the most under-recognized is this is a poorer diagnosis than many cancers. If you've got heart failure with diabetes, your life expectancy is less than most cancers, with the exception of small cell carcinoma of the lung. This all requires urgent treatment. So when it comes to modifying this risk factors, well, there are many pillars that we can base this on, and that can come from things like the multiple risk factor intervention. We have to go for this entire multiple risk factor. And the classic data from this still comes from the STENO2 trial. Very small study, only 160 patients, and people were randomized to receive a multiple risk factor intervention approach compared to identified problems as they arise. And that demonstrated a benefit that has still present 20 years down the line, many, many years after the study was ended and people were all put onto the same approach. So what are these multiple risk factors that we're talking about? Well, first of all, of course, there's lifestyle modification. Now, lifestyle modification is hugely controversial, particularly after the Look Ahead study was stopped due to futility because the lifestyle actually failed to show any benefit. But that's because patients have differential engagement with lifestyle intervention. You've all got them. Patients that if you give them advice and say, you need to lose weight, you need to exercise more, half of them will walk out and say, "Nah, what does that doctor know anyway?" The other half will really take it to heart. They'll go on a diet, they'll exercise on a regular basis. And if you compare the group who actually did engage with those who didn't, those who actually lost weight versus those who didn't lose weight, we saw a massive reduction in cardiovascular risk, in stroke, in presentation to hospital, in needing for any additional components. So lifestyle intervention, although many poo-pooed it as a strategy, is still a cornerstone of the management of patients with any of these cardiometabolic and type 2 diabetes. The next on the list is glycemic control. Now, glycemic control alone is different from choosing specific drugs. Glycemic control alone has a rapid effect on type 2 diabetes microvascular complications. But when it comes to macrovascular complications, actually the benefit is best achieved by doing things very, very early on. Actually, in the UK PDS, which is still cited as one of the reasons for managing glycemic control better, it took decades before we saw a real benefit in terms of clinically meaningful macrovascular responses. And when you look at the other studies that have followed with that, the further you get on in disease progression, the more difficult it is to get benefit from glycemic control. Now, if you compare that to studies that have been recently performed, such as the Verify study, which looked at very early metformin plus DPP4 inhibitor given on day of diagnosis, what that saw was at the end of a 5-year period, very few patients needed any progression of their diabetes therapy. And although it was a very small numbers, you're not able to conclude things conclusively based on the numbers that they used, there was a numerical advantage when it came to cardiovascular events, even within that 5-year period. So the suggestion is when it comes to glycemia, what we need to look at is rapid early glycemic control. The analogy I always use with my patients is if somebody bought you a brand new car tomorrow, would you wait until the car was broken before you started servicing it? Or would you start servicing it from the day that you bought it? Clearly, you'd look after your property from day one because you know it's going to be expensive to replace an engine. Yeah, when it comes to diabetes management, the strategy seems to be very much about leave it until it's broken and then try and fix it. Now, when it comes to using drugs that are really effective at fixing the broken components, we've got two classes that have really shone in recent times. The SGLT2 inhibitors, that's empagliflozin, canagliflozin, and dapagliflozin, have all demonstrated tremendous benefit in patients with heart failure and renal failure. If you've got a patient with type 2 diabetes and heart failure, or type 2 diabetes and renal impairment, they should be on an SGLT2 inhibitor. And I'd ask you to look closely at what your local licensing, what local is available. But if they've got heart failure and diabetes or renal failure and diabetes, they should categorically be on an SGLT2 inhibitor, irrespective of what their HbA1c is. When it comes to the GLP-1 analogs, though, we do have a slight discrepancy in the GLP-1 analogs. We've got those that are analogs specifically, and that is the dulaglutide, semaglutide, liraglutide. They are all demonstrating cardiovascular benefit in atherosclerotic events, TIAs, myocardial infarctions, strokes. The GLP-1 receptor agonists, the exendin 4-base drugs, that's lixisenatide and exenatide, actually are very, very good at glycemic control and weight loss, but may not have the same benefit as the analogs. And so therefore, we'd always recommend use of a GLP-1 analog, liraglutide, dulaglutide, semaglutide, in a patient who's had an atherosclerotic event. And speaking of atherosclerosis, that moves on to the third pillar of the multifactorial approach, the management of dyslipidemia. Suffice it to say, we should be getting the lipids down in just about every patient who we are seeing. We should be aiming for a 50% reduction in their LDL cholesterol and a target of less than 1.8 millimoles per mole or 70 milligrams per deciliter with whatever agents that are available. I personally would recommend every type 2 diabetic patient should be being treated with a statin. And at that point, you then start thinking, should we be adding in something like an exenatide? Should we be adding in some of the fish oil treatment? Should we be looking at a PCSK9 inhibitor? And these are very much based around local availability. I would say the benefit of the Viaspar, the fish oils, has been grossly underestimated. Has a tremendous use, particularly in our diabetic populations where the statins are not as effective. Then we've got blood pressure control. And right since UK PBS, we have known that tight blood pressure control is absolutely essential for people with type 2 diabetes. And again, there is a proven legacy effect on this. The longer you leave it to get it under control, the more difficult it is. And the target should be around 130 on 80 if you've got high cardiovascular risk, or 140 on 90 for the lower cardiovascular risk. Lastly, from this multifactorial response, the platelet inhibition is something that has changed since I started practice. When I started training, every person living with diabetes should be treated with aspirin. We now know that that's not necessarily the case. And actually, we only use platelet inhibitors as secondary prevention within a setting of a patient living with diabetes. So if they've got diabetes, they need to have had another event. We only consider them in those who've got a really high primary risk, those who've got multiple risk factors as well as a strong family history. Would you consider the antiplatelets? And that's purely because the benefit of giving aspirin routinely is counteracted by the risk of the GI blood loss or the complications of having aspirin in the lower risk population. So what we have here on this table is just that overall summary. Glucose control, target HbA1c of less than 7%. Metformin plus DPP-4 inhibitors are brilliant as a first-line combination therapy. Then SGLT2s and a GLP-1 analogs can be considered as an alternative to add in if they develop atherosclerotic events. Blood pressure, look at really good blood pressure control with the ACE inhibitors, the calcium channel blockers, the thiazide-like diuretics. Very often, look at dual therapy initially if the blood pressure is not going to achieve target with a single agent. When it comes to the lipid control, we've got very clear guidance. We use a statin first line, then add in ezetimibe, the fish oil or the PCSK9 and get on board there. And always look at weight loss and smoking cessation. Now, there are multiple guidelines these days for looking at the best way of managing them. And these guidelines have shifted from what they used to be. The guidelines when I trained were all about get the sugar down. Now we've got atherosclerotic targets, we've got heart failure targets, we've got renal targets, we've got CKD targets. And in the top right-hand corner, we have the really important component that we need to review regularly. We need to be tackling the clinical inertia. We are no longer happy to treat to fail. We need to try and get these patients under control from day one. On that note, I want to thank you for your attention and look forward to the discussion that we're due to have. Thank you very much.
Thank you, Professor Strain, for your excellent talk. And it's my pleasure to and honor to welcome Professor Azad Khan and his decades of experience in formulating different guidelines across Bangladesh to give his perspective on this type 2 diabetes mellitus, which has been kind of an epidemic in Southeast Asia. And who could be a better person to talk about this kind of epidemic, which has been growing over the years on the perspective of Bangladesh? Sir, the floor is all yours. Please enlighten us.
Well, John, thank you very much for inviting me. It's a pleasure for me to really to hear Professor David Strain. It's an excellent, what should I say, excellent summary of the thing. Such a complex subject, he has made it easy. I'll just mention one or two points that he mentioned that type 2 diabetes is not simple insulin and sugar. It's a complex disease. And for its early identification and management, one has to consider many things. I would like to also welcome my colleagues, local experts from here, and also the other executives of the Sun Pharma. But without wasting any more time, I will just emphasize one point, that is prevention. and early identification of the disease, because which is the main topic of today, the early identification. Because we know that diabetes is epidemic, and epidemic is still rising and is rising faster in developing countries like Bangladesh than other developed countries. See. We know that it can be prevented, this rise, if we can modify lifestyle or listen to other, just have Professor David Strain has just mentioned. But we still don't consider what will really motivate people to listen to this advice. We should try to work out how this, to find out what language will motivate. You see? That's the topic we are working at the present. It has been a great pleasure for me to attend this, and I wish that the subsequent deliberations will be equally successful and motivating for the listeners. I have been immensely benefited by listening to David Strain, but I think there are other discussants or speakers, so I don't waste any time. I only just finished by saying welcome to you all, and thank you for asking me to be present here. Thank you.
Thank you so much, Professor Azad, for giving the perspective on the Bangladesh on the Bangladesh side to understand better from the country perspective. We'll come back to you with questions from the audience as well. But before that, we'll take the first question from the audience, and I would like to ask Professor Pathan this question. And again, this is a question which is again a little tricky, and just to understand from you in your clinical practice, when you are using a combination therapy of maybe a sulfonylurea with metformin, what are the patient characteristics you probably look into, of whether using a monotherapy or a combination therapy of patients in case of diabetic patients when they come to you in clinic for the first time? Professor Pathan, are you there?
Probably the network is not working.
Okay, so maybe, yeah, I think Professor Pathan is back.
Yes, that is here.
Sir, can you hear us? You are muted. Yeah, I think there is some issue with the network. So we'll take the next question for Professor Pathan, but maybe I can redirect this question to Dr. Faria. Ma'am, in your clinical practice, when you are using a combination therapy of type of maybe a sulfonylurea with metformin or maybe a SGLT2 inhibitor with metformin, usually which are the patient characteristics you look for while using a combination therapy in contrast to monotherapy?
Thank you. Thank you, Dr. Jayanta, for asking me the question. First of all, I'd like to thank our today's speaker,
thank you very much.
Mr. David Strain. Oh, sorry, is talking. Okay.
I think probably there is some network issue.
Okay, I am.
Thank you very much.
Yes. Are you able to hear?
The question. Can you hear me?
Yes,
we have in our hand, if you the introductory lecture of the Dr. David about the ominous octave pathway, the different defects are there in the hyperglycemic episode in a type 2 diabetic patient in different combination of 8 pathways of the defects. So when you look for the medication, particular oral medication for the not only glycemic control, but you have to also think for the other metabolic parameters like hypertension, dyslipidemia, and obesity, cardiovascular disease, and other disease. So thinking all these points together, the 2023 ADA guideline has beautifully demonstrated the which combination drug you can use during the treatment. If you think it is the cardiovascular risk, or a patient has already cardiovascular risk or heart failure, so what are the drug you can combine together as GLP-2 you can give, or you can give also the GLP-1 analog. Sometimes GLP and GLP-2 alone to one not only the reduce of the cardiovascular benefit, also the for the obesity point of view. On the other hand, if you find the patient has also renal failure, then you can also have a good opportunity to combine both SGLT2 or renal failure. So depending on the patient perspective, type, obesity, hypertension, the other disease has already have done by maybe the early stage to reduce the progress of the cardio, the complications.
Yes, I think we understood some bit of what Professor Pathan was discussing regarding the combination therapy that could be probably introduced in patients who are diagnosed with type 2 diabetes for when they're coming for their first therapy. Okay, Professor. So I will redirect the next question to Dr. Faria. And okay, so this question is interesting and in fact quite unique also. So we have Dr. Arifa asking regarding a diabetic patients if they have chronic kidney disease with low EGFR, having high creatinine. Is there any medicine that could be beneficial in reducing the creatinine level, and what could be the other medications that could be used in this type of patients?
Thank you. Thank you for the question. First of all, I'd like to again begin with thanking Professor David Strain for the beautiful presentation and highlighting and enlightening us with the very in a brief period. And the question is actually the renal protection, actually about the renal protection, the anti-diabetic medication and the renal protection. Actually, nowadays, we are not very much dealing with the creatinine, but the eGFR. So the GFR is a cutoff by which we decide which treatment to start or not. And regarding this, among the DPP-4 inhibitor, the linagliptin can be easily given at any GFR level, so it is safe in any level of kidney disease. And considering the renal protection, and at the same time we get the cardiovascular protection also, the ARB or AC inhibitor, that will be give some protection and prevents the progression of proteinuria. And regarding the anti-diabetic medication also, different studies with SGLT2 inhibitors also prove that in the EMPA-REG trial also, it is evident that it also decreases the progression of the proteinuria or albuminuria in the renal impaired patients. So there is actually no cutoff of creatinine, but there is cutoff of eGFR. That is many drugs, all the drugs are given above eGFR 60, and there is some dose modification of all the drugs between 30 to 60. Exception is the linagliptin that can be given easily, and insulin of course is given at any GFR.
Okay, we understood. Thank you, Dr. Faria, for your comment on this question. And we'll go ahead with the next question to Dr. Samad. And this question is from Dr. Enamul Hawk, and he's asking, can SGLT2 inhibitors and metformin be used in breastfeeding mother?
Thank you, Dr. Enamul, I think so.
Yes.
Dr. Enamul, yes. First of all, I must thank Dr. David Strain for his nice presentation and pointing out the initial of the complications, how we can prevent those things. So the question is, can we use the SGLT2 inhibitor and metformin in lactating mother, I think.
In pregnancy.
Yes, that was lactating
mothers, yeah.
Yeah. So far I know, the metformin, there is no harm to give the metformin in lactating mother. And SGLT2 is still, again, we are using if the kidney function is preserved and, there is no complications of other diseases. And it is better to keep if the mother is obese, you can keep. there is no harm.
Okay. Thank you, Dr. Samad, for your comments on that. We'll go back to again Professor Pathan on another question, and this is a very direct question. Which is the best? And this is from Dr. Jannatul Fardousi, who is asking, which is the best treatment option for type 2 diabetes, whether it is oral hypoglycemics or insulins? And probably you can enlighten us at which stage in diabetes you would probably initiate insulin from the oral drugs. I think that would be the probable, the directed question towards you.
Definitely, thank you very much. Definitely, the question is asking about the which drug should be the best option for the management of diabetes. Definitely is.
Professor Pathan, I think your
can
voice
give.
is breaking. If you can turn off the video, we could have probably a better audio feed.
Yeah.
Can you hear? Can you hear now?
Yes, we can hear now. Please.
And the question they are asking about the use of whether you should start with oral hypoglycemia agent or insulin at initiation of therapy. Definitely, for the better management of good glycemic control and maintain a good glycemic control, insulin is the best of all. Not only that, whatever may be HbA1c glycemic exposure, insulin the best to reduce very quickly. And it also important if you start insulin earlier, then you could also avoid the inertia for the use of insulin, because we have seen in our own practice that lots of people patient taking oral hypoglycemia, though they need insulin because of the secondary failure, and the beta cell is not so much there to improve the insulin secretion. So the physicians and the patients also reluctant to start insulin. So to avoid inertia, insulin is the best way to do glycemic control and metabolic memory to reduce the complication. And along with insulin, you can also use the other drugs when you think about the complications with macrovascular complication, cardiovascular outcome study, what you've seen, renal outcomes, what you've seen. You can use the GLP-2, the GLP-1 along with the insulin together to not only the maintain a good glycemic control, also to reduce the complication what is going to progress in type 2 diabetic patient.
Thank you, Professor, for your comments on that. And I think, in fact, in India as well as in Southeast Asia, we have a lot of usage of sulfonylurea and their combinations. And I would also like to thank Professor David Strain myself for giving such an excellent talk. And Professor Strain, if you can give your perspective of using the safer sulfonylureas, as we call it, the second generation ones and the newer sulfonylureas, based on their lesser number of hypoglycemic events that we see in your clinical practice, and also what would be your take on the newer safer sulfonylureas?
So yeah, it's a really important and very, very topical discussion now, because sulfonylureas are incredibly cheap compared to many of the others, and for big populations these are the affordable option. But there is always this hangover in the back of our minds that are we giving drugs that are potentially doing harm? But it's really important to say that the data about sulfonylureas and severe hypos and harm all date back to the chlorpromamide and tolbutamide and drugs that we just don't use anymore. And when we start looking at the glipizides, the newer generations, actually these are very well tolerated. And the hypo risk is a lot lower than has ever been estimated in the numbers that go before. Similarly, there are many, many patients who can tolerate these for decades without it causing any hypos whatsoever. Now, one of the interesting things with these newer drugs is they work much better at the optimum dose rather than a low dose. And there is this misconception that if you start on a really low dose and work up slowly, you'll lower your risk of hypos. When actually at the optimum dose, the dose that they're designed at, they have a balanced effect on insulin and glucagon. And we've seen recently in some of the outcome trials, so for example, Carolina, that was a head-to-head with a DPP-4 inhibitor and the sulfonylurea, there was absolutely no difference in outcome. So this story that sulfonylureas are in some way doing harm dates back to the old drugs that did have a very long half-life, caused the unequivocal increase of insulin irrespective of whether it was needed or not. With the newer ones, that's not the case. I've got many patients that I've got on these and have stayed on them. I would never go about changing someone who's well stable. There is a small group of people that we do caution the use. These are people who are the more mature, the elderly, the frail individuals. And that's not because we are worried that this hypo is going to have a dramatic impact on them, but it's more about the fact that the sulfonylurea, if they do have a hypo, the consequences of that hypo are much more severe. So if you've got osteoporosis, for example, or if you've got Parkinson's disease or some other comorbidity, consequences of a hypo for that individual is far more dramatic. The other group are those who've got cognitive impairment, people who are at risk of dementia. We do know that later in life, hypos, particularly severe hypos, do cause a more rapid progression of the dementia. But that's something that we start worrying about in the late 60s and the early 70s, not in the early phase of diabetes. And actually recently, the Trimaster study that we did here in Exeter did demonstrate that actually from the newer generation of sulfonylureas versus the thiazolidine diones versus the DPP-4 inhibitors, actually the adherence and the tolerability was very, very similar across the board. And so from that point of view, I'm quite happy to be using it for these younger, fitter patients with type 2 diabetes.
Thank you, Professor Strain, for your talk or for this concept of using the newer sulfonylureas as we understand. And on this aspect, I'd also like to ask Dr. Faria regarding her experience of using sulfonylureas, specifically the newer sulfonylureas in newly diagnosed patients.
Regarding the use of sulfonylurea, actually the many patients are using sulfonylurea, especially in the low resource area like our country. And in moderate hyperglycemia, also the first drug may be chosen as sulfonylurea, and the newer generations, the glimepiride and gliclazide are widely used in our country also. And the patients are benefited for a period of time actually with these drugs. And along with the combination of different mode of action, the complementary drugs like DPP-4 inhibitor or SGLT2 inhibitor and metformin, of course. And from that on, now the treatment pattern is changed from the early combination also. The sulfonylurea metformin or sulfonylurea metformin DPP-4 inhibitor may be given in a patient with moderate hyperglycemia. And in that case, the sulfonylurea is working very good in that particular patient. Of course, the treatment is individualized for each and every patient.
Sure, absolutely.
Jayanto, if I may add here, see.
Please add, sir.
I think, yeah, conceptually, one has to understand that clinical medicine is not a pedantic science. It is what is appropriate at that appropriate place and time, you see. One has to consider socio and economic condition of the patient. Let's say patient cannot afford treatment, they can afford only sulfonylurea. Then should I not use sulfonylurea? Yes, one has to consider the socio-economic condition and the situation where it is. If I'm given a choice, although I'm not a practicing diabetologist, if I'm given a choice in let's say, is a well-to-do man, he has no problem of money, then I'm not going to start with sulfonylurea, that's for sure. But if a person is very, very poor, he can't afford anything, then I should use sulfonylurea.
Thank you, sir, for giving your perspective on this as well. And I'll take the next question for Dr. Samad, but I think this question is directed to Dr. Faria directly. So we have Dr. Mahbub Rahman Amil asking, if the spot urine microalbumin is more than 150, what should we do?
Oh, yes.
And
Faria. Yeah, you give answer.
Okay. Always during diagnosing the microalbuminuria or proteinuria, that is a single sample is not always diagnostic. because there may be several other confounding factors that may cause proteinuria. But in case of a huge proteinuria, we can assess for the 24 hours sample also to get the actual amount of protein losing, and then look at the renal function status as well, and then try to improve or stop the progression of this proteinuria, and also look at the other causes that causes this proteinuria. If there is on other factors which are causing this proteinuria. Regarding the diabetes management, of course, we should start treatments that helps in the diabetic management as well as the proteinuria prevention. But before that, the important thing is the confirmation of the proteinuria, persistent proteinuria. And of course, we should give treatment in the anti-diabetic medication and also the antihypertensive, consider these drugs which prevents this progression of microalbuminuria or proteinuria.
Sure, ma'am. Sure, thank you. We'll ask the next question to Dr. Samad, and this is again a kind of a direct question. How much is the HbA1c reduced if DPP-4 inhibitors are used alone? But I think they are probably not used alone. Probably will have metformin being used first. So
yeah, thank you for the question.
Yeah,
I think what I can say, the disease is multifactorial. So one drug cannot control this. So usually we are studying a type 2 diabetes, the combination drug, which is advocated nowadays. So DPP-4 inhibitor plus sulfonylurea or any other agent, actually that works better and reduces the hemoglobin A1c. And as you know, if you can reduce even 1%, there's a lot of impact on your health, and it can reduce the complications.
True. Sure, of course. Thank you, sir, for the comments. We can take another question also, and this would be for Professor Pathan. So we have a question asking that in gynecology we see a lot of doctors prescribing metformin during pregnancy, and again in long-term data, do you think whether this is safe in all the trimesters?
Thank you, Dr. Janto. That is a very much the question. Metformin used during pregnancy is a more debatable one still now, because long-term safety data about the baby is not there, but the safety data of the mother pregnancy is there. So it is safe for the mother, but whether it is safe for the baby or the fetus or long-term consequences there's no long-term safety data of the metformin use after following the baby for a longer time. Though the data is there up to 2 years or 2.5 years, the data is there. There is no harm is found in the use of the metformin on the fetal or the baby. But the most important one is the use of the metformin is that the distribution of fat of the baby has been changed lots, and that may be sometimes in the future may cause that type 2 diabetes of the baby is there. But the amount of the lactic acidosis, what is found in lactic acid found in the metformin used in the mother, because the baby is anoxic condition in the mother's womb. The anoxic condition might increase the level of the lactic acid, and lactic acid may cause some defect in the dysfunction of the development of the psychomotor or the development of the brain. We have the long-term data is not there. Psychomotor deficiency is there, the long-term use of this metformin, or the long-term study is not there for the baby. Either this cause a psychomotor disorder of the baby, or the what we call nowadays we have lots of patients are suffering from the development, mental development problem for the baby, and that of the that cannot be still now. They have the data is not long-term data is not still available, but you can use higher the insulin cannot be. So we can use this metformin in some restricted way, but I think so for the safety purpose, yes, there's no long-term data is not available. So safety purpose, insulin is the best choice for the maintaining of glycemic control of the mother.
Thank you, sir, for the comments on this question. And I think there is another question which is linked towards it. So probably insulin would be the most common drug being used during pregnancy.
Right.
Sure.
I mean, it is safe. It does not cause the placenta.
True. Okay. We have one last question again for Professor Strain. And this is a question from Dr. Nasreen Akhtar, who is asking, what could be the best choice of anti-diabetic medications in patient who has hepatitis? Professor, you are on mute.
Of course, it had to happen sooner or later. It depends on the underlying cause of hepatitis, and we are starting to see a growing evidence base, particularly of the GLP-1 analogues in patients with NAFLD, the non-alcoholic fatty liver disease. And that's a really interesting concept in its own right, because there's very, very few GLP-1 receptors. In fact, the first study suggested that there weren't any GLP-1 receptors in the liver itself. And yet the process of giving the GLP-1 analogues does dramatically reduce fatty liver within these individuals. Now, I want to stress that they don't have a licensed indication for that use as yet. But basically, the key component of managing a patient with type 2 diabetes who's got liver disease is just about the glycemic control and what is right for them based on their other diseases. And also what's going to have benefit within anticipated life expectancy. Remember that if you've got severe liver disease, actually it's pretty much irrelevant what we do from the diabetes point of view, because that severe liver disease will have a much more dramatic impact on their quantity of life than anything we are going to do. So what we're talking about are the early stage of liver disease before the liver function tests have moved to 3 times the upper limit of normal. And at that point, good glycemic control, metformin, we'll use it where we can, being aware of the risk of lactic acidosis. Then I would be looking at potentially a GLP-1 analog or a DPP-4 inhibitor. I'm bringing in the SGLT2 inhibitors. I think they probably do have some additional benefit, but the evidence for that is still in the development phase. This is actually one of the few cases where I would be cautious about the sulfonylurea use, just because we know that sulfonylureas do cause a very, very slight increase, and I stress a very slight increase in fat deposition within the liver, but it's because we've got the multiple choices that we have available elsewhere.
Thank you, Professor Strain, for that comment. So we'll take the last question, and this will be for Professor Farooq. And there are actually 2 questions. So the first question is, should we use SGLT2 and SGLT2/1 inhibitor for MODY patients? So I think for SGLT2 and 1 inhibition, and both SGLT2 and 1 inhibition for maturity onset diabetes, whether this could be used. And the other question is, should we use Lispro and Glargine in pregnancy?
Lispro, and second question is that Lispro, Glargine, though
Yes.
the data is there for the Glargine use in the long-term data is not there for the use of Glargine during pregnancy period, but we can use the determinate and safely because lots of data is there from the determinate safety point of view. But nowadays, the offline, there are lots of patients getting the Glargine for the better control of fasting or BP meal control of glycemic control in the diabetes patient. And Lispro, aspart and Lispro it is applied, and it is already approved by the FDA for use of the post meal blood sugar control during pregnancy period. By aspart and Lispro can be used safely. But glulisine is still not enough data is there to use safely glulisine in pregnancy period. This is one question. And first question, what is the SGLT2?
Sir, so the question is, should we use SGLT2 and 1 inhibitors in maturity onset diabetes mellitus? But to my understanding, I think there is only one SGLT2 and 1 inhibitor which is approved currently, and that will be sotagliflozin. But I do not think that there is any data.
I think so. I have no idea about the point of what asking is that, but I have no idea about it. The use of SGLT2 maturity onset MODY, I think so.
True, yeah, MODY, yes. So they have been used
Modi.
for the treatment of heart failure, and recently they got approved for heart failure also, that is sotagliflozin.
Yes.
But for MODI, I have not heard. I mean, this could
No,
be.
I have no data is able. I think don't think so. Then enough data is there for the use of the GLT2 in the Modi patients.
True. Thank you, sir, for your comments. And I think we have reached the end of the program. And due to time constraint, I would again invite Professor Azad Khan to give his final comments on our discussion. Sir, if you could give your final comments today.
Well, my final comment is thank you and thank you all. But I must say this has been a very enlightened discussion, especially the lecture by David and the lively participants. Yeah, we could see it from the probing questions. And we will be having another webinar, webinar 2, which we will notify in due time. And thank again everybody, and good night.
Thank you, Professor Azad Khan, for your kind words, and we look forward to the future webinar as well. I would also like to thank Dr. Faria, Dr. Samad, and Professor Pathan for their active participation and dealing with the questions that we have. And of course, we have Professor Strain for such a lovely talk today. I also learned a lot of things. In fact, it's a good refreshment of the newer things that are currently happening in diabetology and to understand more the pathophysiology. So thank you so much, gentlemen, for joining in today evening. And good afternoon, good evening again, Dr. Professor David Strain. Thank you again, and have a good night. Bye-bye. Thank you from San Francisco.
Okay, bye-bye. Thank you.
Thank you,
Thank you.
Professor.
Bye-bye.
Thank you so much.
Thank you.